they're actually not very picky in terms of their hosts. So you see dog fleas on cats and cat fleas on dogs, which is the more common scenario. You'll see poultry fleas on dogs, especially in the Carolinas. But there are certain fleas that historically have been the ones that carry most disease.
That's Dr. Dirk Elston, and this is Dermatology Weekly, the weekly podcast from MD Edge Dermatology. I'm MD Edge editor Elizabeth Mechcatie.
And I'm MD Edge editor Terry Rudd. Today, the flea bite is a problem for a variety of populations, from those in natural disaster scenarios to pet owners. Dr. Vincent DeLeo talks with Dr. Elston about cat fleas and other issues in environmental dermatology. Dr. Elston also discusses vector-borne diseases, including endemic typhus and cat scratch disease caused by organisms transmitted by fleas. And he outlines interventions to remove fleas and treat their bites.
In the news, states aren't waiting for Congress to address high drug prices. An FDA advisory committee supports approval of daily oral immunotherapy for peanut allergic children and adolescents. And Dr. Henry Lim discusses recent data on sunscreens in an interview with MD Edge reporter Carrie Oakes.
You can reach Dermatology Weekly by emailing us at podcasts@mdedge.com. You'll also find that email address in the podcast description.
And now the news.
Whether Congress will act this year to address the affordability of prescription drugs remains uncertain. But states aren't waiting. So far this year, 33 states have enacted a record 51 laws to address drug prices, affordability, and access. That tops the previous record of 45 laws enacted in 28 states set just last year. Those findings are from the National Academy for State Health Policy, a nonprofit advocacy group that develops model legislation and promotes such laws. Among the new measures are those that authorize importing prescription drugs, screen for excessive price increases by drug companies, and establish oversight boards to set the prices that states will pay for drugs. And more laws could be coming before year's end. Of the handful of states still in legislative session, including California, Massachusetts, Michigan, New Jersey, Ohio, and Pennsylvania, debate continues on dozens of prescription drug bills. In New Jersey alone, some 20 proposed laws are under consideration. It's been a bipartisan push in state legislatures, with Democrats and Republicans backing bills to tame drug costs. But experts note states can only go so far in addressing rising drug prices. Federal legislation is necessary to have a major effect on the way the marketplace works. Hemi Tuerson is Director of Health Programs at the National Governors Association. She says federal lawmakers are keeping a close eye on state initiatives to gauge where legislative compromise may lie. But political divisiveness, a packed congressional schedule, and a looming election year could stall momentum at the federal level. Priscilla Vanderveer is a spokeswoman for the Pharmaceutical Research and Manufacturers of America. She says the pharmaceutical industry has opposed most, though not all, state bills. Many states have passed bills that look good on paper, she says, but that pharmaceutical makers don't believe will save consumers money.
The FDA's Allergenic Products Advisory Committee voted to recommend approval of AR-101 peanut protein capsules developed to desensitize peanut allergic children and adolescents. The oral immunotherapy's indication would be to reduce the incidence and severity of allergic reactions, including anaphylaxis, after accidental exposure to peanut in patients aged 4 to 17 years with a confirmed peanut allergy diagnosis. Support for approval comes with conditions, including a box warning in the label. The FDA typically follows the recommendations of its advisory panels, and if approved, it will be marketed as Palforzia. The advisory panel voted 7-2 that the data on efficacy were adequate to support approval. The panel also backed the therapy's safety data in an 8-1 vote. The lone no vote on safety came from a panelist who was concerned about the dearth of long-term follow-up of treated patients. The dissenting panelist also noted that the children who received the treatment during the dose escalation and maintenance periods had twice the number of allergic reactions requiring epinephrine as patients on placebo. The product comes in individual packs of capsules filled with peanut protein. Treatment begins with between 0.5 milligrams and 6 milligrams over 1 day, then escalates every 2 weeks to 300 milligrams, or until there's a reaction requiring epinephrine. Passing at least a 300 milligram dose was the requirement for exiting the escalation phase and moving on to the daily year-long maintenance phase. The 4 efficacy studies presented showed that 96% of patients tolerated 300 milligrams, 84% tolerated 600 milligrams, and 63% 1,000 milligrams. The product's manufacturer didn't explicitly address the potential cost of therapy, but a recent review by the Institute for Clinical and Economic Review estimated the cost to be $4,200 per year. Palforzia would have to be taken every day for an unknown amount of time to maintain peanut tolerance.
In the final installment of our interviews from the summer meeting of the American Academy of Dermatology, Dr. Henry Lim spoke with MD Edge reporter Kari Oakes about some of the recent news about sunscreens. Dr. Lim is a dermatologist at the Henry Ford Hospital in Detroit and a past president of the AAD. Dr. Lim talked about the potential environmental effects of sunscreen ingredients, as well as results from the FDA's sunscreen absorption study, published in JAMA in May. That Phase 1 study found that maximal application of 4 sunscreen formulations resulted in plasma concentrations of sunscreen ingredients that exceeded the agency's threshold for waiving toxicology studies for those products. He also discussed whether the use of sunscreen could be contributing to the increase in cases of frontal fibrosing alopecia.
Dr. Lim, we're here in New York City at the summer meeting of the American Academy of Dermatology, and you kicked off this morning's sessions with sort of a deep dive into the relationship between certain chemicals found in sunscreens and the potential for environmental degradation, particularly coral reef bleaching. This is a complicated subject, but maybe you could talk to us a little bit about it.
Sure, I'd be happy to. Essentially, what is now known is that coral reef bleaching is a phenomenon that had been observed more frequently compared to the past, and the question is that what is the cause? Sunscreen has been associated with it mainly because it has been found that the sunscreen active ingredients are found in water, in seawater, as well as in coral reef area. The best study on that has just been recently published a few months ago by Dr. Mitchell Moore, and she studied waters around Hawaiian Island area, and she measured very carefully the concentration of various active ingredients of sunscreen. What she found indeed is there are active ingredients on sunscreen. I call it UV filters, ultraviolet light filters, UV filters that are present in water. However, those concentration was significantly lower than what has been found in the past in laboratory setting that would cause the demise or the killing of the coral reef. So in other words, in the coral reef has been studied in a laboratory setting. If you put UV filters in the water in the laboratory setting, the coral reef would be bleached, would be killed. But the concentration that is needed to do that is in the laboratory setting is significantly higher than what has been found in the actual real world setting in Hawaiian water, indicating that sunscreen and the active ingredient of sunscreen is probably not the only or the major cause of coral reef bleaching. In fact, there are multiple studies that have shown that ocean warming, the warming of the ocean water, is a very significant and a major factor for coral reef bleaching. I think overall they are multifactorial for this major side effect. Sunscreen is just a small component of it, and I think we need to continue to keep our minds open on this very topic.
And so more research is needed. People need to keep talking in a dialogue between the disciplines, between dermatologists, those who study the ocean, those who study life in the ocean.
Absolutely. I think as dermatologists, what we need to make sure is that we can continue to communicate to our patients that we do know, and the science is very strong on this, on the side effect of excessive sun exposure. We all see in our patients, we all see it on a daily basis in our practice, that excessive sun exposure is associated with multiple side effects, ranging from wrinkling to development of freckles, but more importantly, development of skin cancer. So that part of science is definitely very, very strong. So I think we need to continue to educate our patients to make sure that they know that need to continue practice photoprotection. And photoprotection is a topic that I think we need to think about it as a package. That photoprotection should include seeking shade when outdoor, applying applying sunscreen on the exposed area only, but also as importantly, wearing clothings, white brim hat, and sunglasses. That would be the total package. There are a lot of advantages and benefits of being outdoors. So I think we need to continue to encourage those who want to be outdoor to participate in activities or to enjoy life in general. They should continue to do that, but they do need to practice photoprotection, knowing that sunscreen is just one component, not the only component, but just one component of the photoprotection package.
And I will say, as the mother of young adult children who raised kids leading an active outdoor life, the range of photoprotective clothing available now is much greater than it was when my children were infants. And there are comfortable, affordable options for people.
Absolutely, yes.
Earlier this week, readers of the New York Times might have seen a column called, "When You Wear Sunscreen, You're Taking Part in a Safety Study." This cited an FDA randomized trial showing that chemically active components in sunscreen were found in the blood of people who were using sunscreen. Can you talk about if this is something that dermatologists should tell their patients to be concerned about, or just stay the course?
First of all, I think the title of the article is very misleading. The purpose of the FDA study is not to do experiments per se. What they are doing is that, and it was a very well done study, what they're doing is that they apply sunscreen under maximal usage condition and measure the absorption of the UV filters into the blood. The maximal usage condition, they define it as applying sunscreen to 75% of the body surface, using 2 milligram per centimeter square, which is the concentration that is required by the FDA to do sunscreen SPF testing. To translate the 2 milligram per centimeter square, essentially it is 1 ounce of sunscreen from head to toe. We know that through multiple studies and from our own experience, I'm certain, that public do not apply sunscreen at that particular concentration. The average concentration that is used usually is between 0.5 to 1 milligram per centimeter square, so 1/2 than the 2 milligram per centimeter square. Furthermore, they ask the subjects to use the sunscreen every 2 hours, to apply sunscreen every 2 hours, so 4 times a day, because the study is done for 8 hours, for a total of 4 days. Then they measure the amount of UV filters that is in the blood, and they show that indeed there are UV filters in the blood. It's not totally surprising, because any type of material that we put on our skin would get absorbed. That is not surprising. What FDA also emphasize, and a lot of time this point is missed by the public, they emphasize in a paper that was published in JAMA that their findings does not indicate that the sunscreen is not safe. So they continue to advocate to continue to use sunscreen as part of the photo protection package. So I think that part, even in the FDA article, it was emphasized as such. And the other part that I think we need to recognize, all the UV filters has been around since the late 1970s. One of them was approved in early 1990s. But so far, aside from allergic reaction that can occur with any type of material that we put on our skin, there have not been any side effects that had been detected that is associated with the UV filters. So in terms of the safety, there is no signal for safety thus far. So what the FDA is doing is that asking the industry to do studies to make sure that the sunscreen is indeed safe.
Your colleague, Dr. Stephen Wong, in a related talk this morning, also spoke about the fact that the vehicle seems to make a difference in terms of sunscreen delivery. And what advice can dermatologists give their patients in terms of the safest known vehicle if they have these concerns?
Definitely vehicles have something to do with the absorption. At this moment, there's so many variation out there in terms of the products, in terms of formulations, in terms of vehicles. I think it's going to be very difficult to make a blanket recommendation as to which vehicle to choose. Generally, what I would suggest and I would advise my patients is that whatever they like in terms of applying sunscreen. The important part is to have the sunscreen applied. So if they like cream, that's fine. If they like spray, that'd be fine. If they like other forms of vehicles, that would be okay. With the spray, just one has to be careful not to inhale it. So when you spray it, make sure it is sprayed away from, obviously, from your face.
Another interesting topic that was introduced this morning by you was the discussion of a potential association between frontal fibrosing alopecia, which is increasing, and the use of sunscreen. But it sounds like the data are mixed there.
Yes, frontal fibrosing alopecia is becoming more common, definitely. Those of us who see patients would see, on the average, probably a few patients a week with new onset of frontal fibrosing alopecia. There have been 4 surveys, essentially, and these are surveys, so it is a retrospective study that indicate that the use of sunscreen or moisturizer that contains sunscreen active ingredients is associated with the frontal fibrosing alopecia. Several parts that I think we need to recognize that with any type of retrospective study, there are some limitations, recall bias being one. Number 2 is that the studies were not designed to look at which sunscreen ingredient is causing the frontal fibrosing alopecia. So all we can say is that there is an association of the use of sunscreen with frontal fibrosing alopecia without knowing which active ingredient is involved, but also there is no conclusion that we can draw in terms of causation, meaning that what is the cause, what is the effect. At this moment, there is not enough data on that. The other part that is related to that is the titanium dioxide, which is also used, as all of us know, as a mineral filter in a sunscreen product. What has been found is that titanium dioxide or titanium element has been detected in the hair shaft of some patient with frontal fibrosing alopecia. The studies are still early. The number of patients are still relatively small that has been examined. Thirdly is that in some of the control, meaning individuals who did not have frontal fibrosing alopecia in that study, they also contain titanium element in the hair shaft, indicating at this moment we cannot draw a firm conclusion, again, whether titanium particles is causing the frontal fibrosing alopecia, but the data is there. It is something that we should be aware of, that we should be able to educate our patients about.
Taking all of this information and some of the new stories in the popular press together as we're nearing the end of the summer here, what can dermatologists tell their patients going forward?
I think it's important for us as dermatologists to continue to inform the patient, emphasize to the patient the known side effect of UV exposure, excessive sun exposure. We should educate our patients about the proper way of photo protection, which is the package that I have highlighted before. Clothing, hats, staying in the shade, and the use of sunscreen on exposed area. And we can tell patients also if they're concerned about the environmental impact of UV filters, titanium dioxide and zinc oxide containing sunscreen are very safe. They have no known environmental impact at this moment that has been reported. Also, they are considered to be so-called category 1 by the FDA, meaning that they are not concerned about the safety of titanium dioxide and zinc oxide because there is no data to indicate they have any absorption into the dermis, into the deeper layer of the skin. So they're definitely, for those individuals who are concerned, they can use mineral sunscreen. There are limitations with mineral sunscreen. The main one primarily is not very efficient, and because of that, they have to use a higher concentration in achieving the high SPF sunscreen. Because of that, especially for darker skin individual, when they apply those sunscreen, the skin may be somewhat whitish looking. That is unacceptable for many of the individuals. And then don't forget also that for those who practice good photo protection, they need to take vitamin D on the regular basis to make sure they have adequate vitamin D level. In terms of frontal fibrosing alopecia, I think I've just outlined that there are data to show there's association, but clearly there is more studies that needs to be done about that. The data is still very, very early on that.
Thank you so much for your time.
Thank you.
We'll be right back after this message. And now, Dr. Vincent DeLeo and Dr. Dirk Elston.
Today we're talking to Dr. Dirk Elston about cat fleas and other issues in environmental dermatology. Dr. Elston is from the Medical University of South Carolina in Charleston. Thanks for joining us today, Dr. Elston.
My pleasure.
So first, can you tell us more about the fleas that can cause disease in humans?
Well, pretty much any flea. They're actually not very picky in terms of their hosts. So you see dog fleas on cats and cat fleas on dogs, which is the more common scenario. You'll see poultry fleas on dogs, especially in the Carolinas. But there are certain fleas that historically have been the ones that carry most disease. In South Texas and Southern California, it's cat fleas carried on opossums that carry endemic typhus, whereas in other parts of the U.S., including more of California and the Southwest, it's the oriental rat flea that traditionally has been that vector. And then the human flea has been the vector for human plague, often attributed to the oriental rat flea as well. But looking back at the great plagues that took place, although the zoonotic reservoir is the rat flea, once it really starts spreading from person to person, it was human flea infestation, the Pulex irritans, that caused much of the spread, and then later pneumonic plague spreading.
So in your article and in your review just now, you talk about cat fleas and other kinds of fleas. I would assume, though, that the rashes that our readers would see clinically would all be the same. Can you describe the common clinical presentations that should alert our listeners to the possibility of a flea infestation?
So I'll take it in two parts. Number one, since we were talking about vector-borne disease, what would be the things that suggest vector-borne, flea-borne disease? A bubo would be typical for plague. And for endemic typhus, which is more common, it is an often acral petechial eruption, not unlike a milder form of Rocky Mountain spotted fever. And then in severe cases, especially anyone who has had a sulfa drug at the time they're incubating the endemic typhus, it's full-blown purpura fulminans with retiform purpura. That's where I've seen it. I spent 10 years in South Texas, and we would see patients presenting full-blown purpura fulminans, and it could be meningococcemia, but just as likely in that endemic setting, it could be endemic typhus. One of the clues would be looking for the little rickettsial eschar, the little black depressed eschar at the site of the original bite, which is a clue to many rickettsial diseases, and also just considering the possibility. In terms of flea bites themselves, they tend to be on the lower part of the body, so largely knee down, and they are papulovesicular, intensely pruritic, and what we often see is the ensuing prurigo that the patient develops after the flea infestation.
So it's important to realize that fleas don't live on the human host like scabies, for example. They just feed on them. So how does the clinician confirm the diagnosis of flea bite?
There are some fleas that will actually stay on the person. The most common being the common name is the stick-tite flea. It's a poultry flea, and it has a serrated lecinia where once it bites you, it just sticks tight, as the name implies. And that one you might actually find either on dermoscopy or on scraping. But just as you said, most fleas are a bite and run type of injury. Patients with heavy flea infestation, especially those who are homeless or in refugee situations or after natural disasters, the fleas will be on the clothing and on the person, and so you may see them. In other cases, it's really the habitat, where the pet has been and the human just gets accidental bites. If there have been fleas in the house can be unoccupied for 2-3 years. The vibrations of you walking on the floorboard rapidly activate the pupae and they release and the adults come out and they're hungry and ready to bite. So even going into a long unoccupied apartment or abode, you can be readily besieged by fleas. It's a bite that's not unlike a lot of other arthropod bites. The fact that they're grouped on the lower extremity, the papulovesicular or bullous quality does suggest the possibility of fleas. And often the individuals, unlike things like chiggers that are insidious in the actual bite, people are aware of the flea bites. They moved into a new house and they felt something was biting them all over their legs. So the patients are usually aware and consider the diagnosis.
That's scary, but you point out that antihistamines and topical steroids are helpful, but of course a cure requires flea eradication. So can you outline that process for us?
Absolutely. So your best friends in that situation are a good qualified exterminator and a good qualified veterinarian. We treat the humans, as you mentioned, and they treat the environment and the pets. There are flea treatments like fipronil, the brand name is Top Spot, that's been around for a long time, that is applied on the animal's neck and spreads like an oil over the animal's body that are quite effective. There are also oral agents, including those that contain ivermectin, that have been used both for heartworm and flea in the pets, but it really should be a veterinarian. There are some animals like collie dogs where ivermectin can be fatal. And so treating the animal is the province of the veterinarian, not the dermatologist. In terms of the readily available flea bombs and things that you can buy, many of them are permethrin-based or other pyrethroids, and then boric acid has been used. It gets into the floorboards and can be very helpful. I suggest doing it with the advice of a qualified exterminator because it's just misery for those patients who have to put up with the fleas.
That's very good advice, I think. Let someone who knows what they're doing take care of that problem or you'll probably never get rid of them. Now, we know that, flea infestation is itchy and uncomfortable and bothersome, and you've already talked on some of the zoonotic pathogens and diseases that they can cause, which are carried by fleas. Can you just focus on cat scratch disease? Because I never thought of that as being related to fleas.
Yeah, it's interesting because the cat scratch organism is really part of a closely related group of Bartonella-like organisms that can cause cat scratch disease, but they also can cause endocarditis. And they're related to the organism that causes aurora fever and Peruvian warts, Verruga peruana, which is basically South American bacillary angiomatosis endemic. So we think of BA bacillary angiomatosis as an HIV-associated disease, but it's been around in the Andean mountains of South America for eons as a vector-borne disease that produces eruptive bacillary angiomatosis, very much like what you see in HIV patients, again with a very closely related organism. So how does it present in the individual? It presents based not only on your immune status, but also what the vector is. If you have the organism transmitted by a louse, you're likely to get endocarditis, and it's a major cause of endocarditis and death among the homeless and in refugee situations. Whereas if it's a flea, you're more likely to get cat scratch disease rather than sepsis and endocarditis. Not entirely known why the vector influences the manifestation of disease so much, but cat scratch disease, despite the name, is not really the scratch of the cat, it's the bite of the flea that was on the cat.
That's really, really interesting. And treatment of cat scratch, can you touch on that just for a moment?
All of the macrolides can be helpful in treating that disease. The bubo that forms will sometimes need to be drained. Try to avoid it at first to avoid a persistent draining sinus, but sometimes the suppurative bubo will drain on its own or need to be drained. Macrolides long-term have been the mainstay of treatment, but a variety of other antibiotics can be active against the organism. A small minority of kids will have systemic disease, including neurologic disease, and those really should be managed together with an infectious disease specialist.
So that was a great discussion about a real growing problem in our patient population. But if you have a few more minutes, I wonder if we might get personal with you. It goes without saying that our listeners know that you are one of the specialty's most gifted clinicians and teachers, an expert in dermatology and dermatopathology, past president of the American Academy of Dermatology, deputy editor of the Blue Journal, and presently, as we said earlier, professor and chair of the department at the Medical University of South Carolina. So the question is, as the producer of Cutis's Close Encounters with the Environment column, how and when did you get interested in bugs?
Well, interesting story. You do things that you get asked to do in your career. I was military for 24 years, and one of the things that's very important to the military is vector-borne disease, not only during deployments, but the military physicians serve a very important role in global health and in disaster scenarios within our own country. And vector-borne disease is one of the key epidemiologic disciplines that is important to military medicine. I spent 10 very happy years at Burke Army Medical Center in San Antonio. We had the Academy of Health Sciences, which trains all of the non-physician, non-nurse personnel important in medicine. So lab techs, epidemiologists, entomologists, all of those other people in addition to medical technologists who augment us and are part of the healthcare team. I fell in with the School of Entomology, and they needed a clinician with clinical expertise to complement the entomology expertise they had. And it was a lot of fun helping them and learning, very dedicated and knowledgeable people who deploy around the world when there are natural disasters. They're involved in planning aid for emerging countries. When you have a village with no water supply and people are going down to the river, that's where they get the vector-borne disease. Installing a well, mosquito control, it's all part and parcel of improving global health. And the U.S. military has played a very large part, along with the Corps of Engineers, in advancing global health in much of the developing world.
That's an amazing story, and we certainly, I think, are grateful to the military for generating someone like you who seems to really enjoy this area of medicine, even though you were at first, I guess, forced to do it. But that's truly, truly amazing. Are there any final comments that you might have for our listeners?
It has been a pleasure talking to you, and I'm a big fan of some of the great resources that Cutis has available to readers. The man versus environment has always been a niche area that Cutis has excelled, and for whether it's plant or bug or aquatic, most of the good articles have been in Cutis. Also, for any residents who are listening, if they have not looked at the online collections of the past image quizzes, it is a fantastic way. It's like everlasting grand rounds where you see everyone's great cases and great images. So I love them, and I'm sure many of the listeners love them as well.
And that concludes this week's episode of Dermatology Weekly. To get past and future episodes of Dermatology Weekly, subscribe now on Apple Podcasts, Spotify, TuneIn, or wherever you get your podcasts. I'm Terry Rudd.
For Dr. DeLeo, MD Edge editor Melissa Sears, and all of us here at MD Edge, I'm Elizabeth Mechcatie. Thanks for listening.